Hi, good afternoon. Thank you for joining us for our progress update number 8 for the drive to Deprescribe. I'm Sabine von Price-Friedman. I'll be moderating the session today. So today we are offering office hours, which gives us an opportunity to connect with each other and hear from participants about their deprescribing and medication optimization initiatives. So next slide, you know the rule, you know the drill. Please participate. This is really an opportunity for us to learn from each other, from what went well and from the mistakes we made. And the session will be so much richer if you are participating, and the chat is wide open. Michael Sinkler, our pharmacy colleague, is going to monitor the chat for us and make sure that we consider all your questions and requests. So today we are so pleased to have a very important team member with us, and that is Director of Nursing, Kim Ratliff. Kim is the Director of Nursing at Wesley Enhanced Living in Media, Pennsylvania. She's been a Director of Nursing for the past 15 years, but has worked in long-term care in various positions for way longer. So Kim, we are excited to have you participate today and have your perspective today. We have heard from various medical directors, attending physicians, nurse practitioners, and pharmacists. However, we have not had the boots on the ground nursing and nursing leadership approaches, challenges, and tips and tricks presented here. So we are really looking, I in particular, really looking forward to gaining from your experience, since you are, and nursing is obviously so important in this process. So Kim, tell us, what was your journey like in deprescribing?
Thank you, Sabine, and thank you everyone for having me today. Next slide. So we started out deprescribing medication. You can click through those three, just like everybody else, except, you know, instead of just giving the doctor the regular MAR, a list of medications, I thought maybe if I wrote them out for them, and made some suggestions on the form that I made, maybe they would listen and take my suggestions. So I asked them, is this medication necessary? Is that medication necessary? Could this something be less frequent? Can we decrease any doses? And from that, we did get some help and some discontinuing of medication, but not to the scope I had hoped. Next slide. So I thought, well, what can we do? How can we approach this differently? I involved the nurses because they're the ones that are giving out the pills all the time, and they're the ones that want to give less medications and interrupt the residents' lives a little less. So we thought, well, let's see if we looked at medication class and see if we could make any progress there. At that point, we had a little over 11 medications per resident. Next slide.
So that's 11 scheduled medications per day per resident.
Per resident, yes.
That's a solid amount.
That's a solid amount, and way over what's recommended, isn't it? 9 or more is a problem, so it was a problem. So vitamins and minerals, we had people come in with all kinds of vitamins and minerals. So I gave the list to the dietitian. What did she think? Did the residents on these medications, these vitamins and minerals, did they need them? I asked the nurses. So we looked at them and we thought many of them could go away. So we got the physician's approval, and indeed we did get rid of a lot of them. So a lot of vitamins and minerals went away, which was good. Next slide. The proton pump inhibitors, you know, if you go to a hospital, you need a PPI, right? So we got a list of all the residents on the PPIs. Now I met with the nurses and the nurse manager, and we eliminated anyone with a history of GI bleed. Obviously they need that medication. Anybody that actually had GI upset, that got Maalox or complained, of GERD or something like that, we took them off the list. After we looked at that list, I sat down with the doctors and looked at everybody else. Do they really need this PPI? And we had 38 or so residents on PPIs. We discontinued the PPIs on all of those residents that we suggested. And we did give them 3 days of Maalox, like 3 times a day after meals, just to prevent any upset stomach that would cause an immediate reaction, to restart the proton pump inhibitor. And we were successful. I think we have 12 or 13 residents on a PPI now. So we decreased it by 2/3 just by the PPIs, which the night shift was thrilled, and the aides on night shift were thrilled because the nurses weren't going around giving the PPIs in the, at 6 o'clock in the morning and waking everyone up. So it decreased the workload on 11 to 7. It decreased residents being awakened. And actually, we don't have any falls very often anymore around 6 o'clock in the morning. So that was very beneficial and really did take a big chunk of medications away.
May I ask you a question?
Sure.
First of all, I think that is just beautiful, where you can see where the outcomes are way beyond just reducing medication, but everything that goes along with the medication pass. And I'd love to talk with you later a little bit more about medication passes. But the 3-day Maalox, I've never heard that before. And I don't know what, Michael, you want to comment on that, but that's kind of brilliant.
Yeah, no, I don't have anything to add. I hadn't heard that either.
Wow.
Okay.
I struggle with, the rebound, and shall we GDR it, and you gave the 3-day Maalox. Of course, probably patients in renal failure, not the best of ideas, but and that worked for you apparently.
It did, because when your proton pump gets turned back on, you might get some nausea, from it, and the normal reaction is, oh, put them back on it. But the Maalox really helped. We really only had to restart one person who we should really have not had on the list anyway, but we only had to start one person back on the PPI. So it was,
impressive. Yes.
Yeah.
Good thinking.
The proof is in the pudding.
Yeah.
Yes. So it worked. Yes. Next slide, please. Thank you. So alternative medicine, we have people on melatonin, on cranberry capsule, on ginger or ginger root, or whatever alternative medicine they came in on that they thought that they needed when they got there, vitamin E. So we looked at all those, and at this point, when you're in a nursing home and you're 80 to 90 years old, those home remedies or alternative medications, really, the ship has sailed. They're not really beneficial. So we've gotten rid of almost all of them. We still have some melatonin, just, sometimes that's a placebo effect because they think they can't sleep, and we can offer that as their sleeping pill. But we got rid of all of the alternative medications, and we look at all of these classes every month, so no one sneaks in on something that's an alternative medicine that's not beneficial. Next slide.
Can I ask again,
Sure.
because I think this particular, that looks so benign what you're looking at here, and I love this slide, by the way, but that is one of my biggest headaches.
Yes.
This is not benign. If you think
No.
about all the effects these medications have, and especially if you're taking multiple of them and you are frail to begin with. But how did you convince people? Are usually very attached to these medications. And
Yes.
How did that go? How did you convince people to let go?
Yeah, there was some challenges. by this point, it's sometimes more the families
Mhm.
than the resident. We did have one resident who was very involved in alternative medicine, and that's really all she took. So we tried to convince her, and it took us a long time. I mean, we did discontinue, the nurse practitioner did discontinue, and she, you know, really was very, very upset. So we had to restart them, but it's education and all of that. And sometimes, you know, we might just stretch the truth a little, that it interacts with other things they're getting, or they're getting, you know, well-balanced diet at the facility. And sometimes that worked. Yeah, or they're getting other things for their blood sugar. Someone was taking, I forget what it was, taking something for their blood sugar. I said, but they're on medication for that. We can, you know, stop the alternative medicine.
Nice.
Yeah,
Thank you.
sure. Next slide. So in the antihyperlipidemic medications, you know, what are the risks? What are the benefits? And if you're over 85, and the recommendation may even be younger, but we don't have that problem here. So we mostly discontinued a lot of them. There's very few people we have on these medications because they're just not beneficial at this point in life. And, you know, again, there were some families that were a little reluctant, but we did convince them to do it. So, and again, these medications are given at night. And, you know, any nurse in a nursing home will tell you, as soon as dinner's over, unless there's bingo that night, they're in a race to get into bed. So the nurse can't possibly give all these medications at bedtime when the residents are sleeping. So it just enhances their quality of life and decreases the nighttime med pass as well. Next slide. So allergies, colds, a little humor. That's what it looks like to have allergies, colds, or coughs. So, you know, in the middle of winter when it's snowing out, you don't have seasonal allergies. So you certainly don't need your Allegra or Zyrtec or anything like that. So we look at this category every month. And if someone had a cold or something, they certainly don't need to continue their Mucinex. So, but the doctors, you know, just order it and don't have stop dates. So we look at these every month and get rid of them when they've recovered from their allergy or cold.
I think this is a good one. I'm always surprised in my patient population how many people are on a particular drug, let's say Zyrtec. I mean, that is just almost 100% people
Right.
come in with that. And they're very attached. So, and
Right.
some have perennial allergies, but that's the minority. So did you pick a specific month or for that, or did you just go by, do you have allergies usually now or not? And if you don't, then well, how did you manage?
Right. So we started by just discontinuing a lot of them, or if we remembered them being put on something because they had a cold, we took them off. So again, we look at these categories every month just to peek at what's going on. And you know, some people think they came in on Allegra or something, you know, Claritin, because they said they had allergies. And, you know, allergies, sometimes when you're in a nursing facility, the allergies that you had before, you don't really have now because maybe you're not out as much or you're not in your dusty house, gets cleaned more, you know, their rooms get cleaned every day. So sometimes we just discontinued it and they never needed it again. Other people, you know, there are some that we took off and needed it, or there's some that'll just seasonal, but again, we just look at them every month and try to figure out if there's anybody we can stop. Next slide. Anticoagulants. So, you know, if you're looking at someone every day that has an incident report because they fell, maybe the anticoagulant is not the best decision. or if they're getting skin tears and hematomas because they fought with the phlebotomist to get their PTI-NR drawn, maybe the anticoagulant isn't for them anymore. So we really look at this, and this includes aspirin. I had one resident that was bruising all the time, and we're filling out incident reports almost every day. I said to the doctor, does she really need that aspirin? Because, she's full of bruises, and, then we stop it then. So we have very few people on aspirin and anticoagulants that are prone to falling, because the injury from falling and hitting your head is far worse, in my opinion. Next slide. And again, you have to talk to the family because it is a risk-benefit situation there, especially if they have AFib or something. Psychotherapeutic medications. These are the Ariceps and AMDA. It's been my experience that when someone is late stage, I don't think they're really benefiting from these medications anymore. I'm hard pressed to find, except in my own personal life with someone I took care of at home, that these medications really don't work so much. And also, when a resident is becoming more agitated and more combative, sometimes discontinuing these medications removes the behavior. And I've seen that a lot. So these medications, it's good to review them and talk about it. Again, there's risks, benefits. You have to be careful. I did have one resident who the psychiatrist told he had dementia, and he's pretty high functioning. Well, until he went off these medications, and then he wasn't high functioning anymore. And we never did get him. We restarted the medications. It never did bring him back to the level of cognition that he had before. So you have to sort of be careful. But later stages, we've discontinued many of those, and there's been no negative repercussions for the resident. In fact, it has improved some people's behaviors. Next slide. Psychotropic medications. So these class of medications need to be looked at every month, no matter what else you're doing, because people's behaviors, etc. You can try to GDR them. They're very, very important. I also have residents that are started on Remeron, maybe because they're not eating and they're already on another antidepressant. So we look at those also and review anybody that's on multiple therapies for, depression, to see if there's, something we can change. Sometimes they start a medication and then they're really still depressed, so they start another antidepressant. So what can do they still need both? We review them a lot to see if they still need both of those medications.
Kim, I think it's that's a great idea, especially with the new state operations manual that has come out, and it sits on the use of psychotropic meds and duplicative therapy and all those types of things. So, what you're doing is certainly down the center of the fairway for what many of us do, but also what is going to be expected from surveyors. So it's a good point.
Right. Next slide. Okay, urinary medications. So residents that are
the anti-Aricept.
Yeah, residents that are on urinary medications, if they're incontinent, do they still need the medication? Most times not. So you can stop them. If they become bedbound and incapacitated, I'm not sure these medications are helping them any longer. So we look at those every month too. Next slide. Bowel medications. This is my This is my recent one that we started looking at. So I looked at all my residents with bowel medications and realized that they were all getting 2 and 3, not just 1, but 2 and 3 medications. So, if a resident doesn't have a bowel movement in a nursing home, it's a catastrophic event. So, we start the bowel protocol, but then, if it happens a couple times, we get the doctor. And what does the doctor do? They don't necessarily look at what they've been on. They just add something, and then you wind up with 2 and 3. So do they really need 2 and 3 bowel medications? And then, you go and look at the bowel record and talk to the CNA and the nurse. And here, they're having 4 bowel movements a day. I don't want to have 4 bowel movements a day. And I know the residents surely don't. And the CNA is probably at her wit's end if that's what's happening. So we looked at that, and then we talked to the physicians, and we did get people down to 1 or 2 instead of 2 or 3. So that's still a work in progress. Now, I did start this bowel medication process. I thought, well, let me put the pharmacist on it. Maybe he could make some suggestions. Well, that just annoyed the physicians, and I got nothing. So when we went back and presented the physician from the nursing standpoint with our recommendations, we got much further with this topic.
Can I ask you about that?
Sure.
Yeah, there is that sometimes the pharmacist says something and they're being ignored. What did you do differently than the pharmacist? What can we learn from that? All of us, doctors, pharmacists. How did you make your argument? And I think this is actually a fascinating category, because you're right, the bowel movement stacks, and that's good for the emergency when you're dealing with a situation. But if it translates into 3 meds, on an ongoing basis, there's no reason for that, actually.
That's no reason,
I think,
right?
Yeah, so I'm going to actually add this category. I haven't actually looked at bowel movements, so I am going to follow you and add this category. But tell us a little bit about how that communication with the physicians went.
Right. So the pharmacist just wrote, your Sally is on 3 bowel medications. Please review for possible DC. So they got, all the doctors got both. I have 2 physicians here. They both got like 17 of those. So they were not very appreciative of it at all. So I got nowhere. So I went back and looked at everybody and talked to the nurses, talked to the CNA, looked at the unit manager, pulled the bowel regimen and compared the list to that. And then she and I sat down and with my information from the nurses and the CNAs and hers from reviewing the bowel records, we were able to make some recommendations on individual residents, and that went much better, because it was a conversation. The doctor didn't have to read anything or write anything. We just took care of it. So
I want to congratulate you on doing and thank you on doing this. It's detail-oriented work, basically. You're not just saying please review, because the doctor doesn't have the time to do 17 reviews all by themselves.
Right. Which is why my initial stab at reducing medications, I sort of wrote it out for them, but that wasn't enough. But I found that these small chunks of looking at individual categories worked much better. And I never approached them at the same time about 2 different categories at all. Just
so really
one focused area, and that worked much better, because they don't have a lot of time. They're coming in here early in the morning to see their residents, and then they're off to other facilities. So and they don't know the residents as well as we do, or the families, or what the families would be open to about medications.
Wow. Really a wonderful overview of how to approach polypharmacy. I mean, this is you're just almost summarizing the entire year and a half that we have had, and I want to congratulate you on this. What was your outcomes?
So we went from 11 a little over 11 medications per resident, average to 9.
Wow, that is an almost 20% improvement, and
Right.
that is wonderful. Tell me what else it did. So you already talked about, which I wasn't aware until you mentioned it, that people get woken up early for their PPI. So
Yes.
that's huge if you don't have to do that. And the
You don't
fall,
have to do that.
yeah,
Yes.
yeah.
Because,
What about-
they ring the bell because they're up, because the nurse woke them up. So yeah, it was great to reduce that.
What about other things? What effect did it have on the nursing workload for you?
Well, it certainly has decreased the workload on the residents, with the residents. We also went to open med passes, so the nurses don't have to keep going back to give different medications. It reduced their workload, and the bowel movement situation that certainly helped the CNAs. The residents weren't over medicated for their bowels. But for some residents, it eliminated all of their medications. So, that nurse doesn't have to go in. They, of course, go see the resident, assess them, and so forth. And the other thing is we were able to get rid of a lot of behaviors in some cases, because the medications were causing behaviors or discomfort or, what have you. So it's had a very positive impact on the nurses and their workload, so they can do, more important things, like just being with the residents, assessing them, and
Doing
being
nursing
with,
work, holding hands and
right,
assessing and
really being a nurse. Yeah, it's been
Tell me,
great.
may I ask a follow-up question?
Sure.
So, and that is, tell us more, if you can, in a nutshell, and Michael, if you want to elaborate on that too, about Open Med Pass. What is Open Med Pass?
So our medications aren't ordered to be given at 9, 1, 5, 9. We give them, morning, so they get their medications in the morning, the afternoon, early evening, or evening. So it allows the nurse more flexibility to, they don't have to be done their 9 o'clock med pass by 10 and start at 8. They have more time to work with the resident, and when the resident awakens, to give them their medication then, or, certainly there are some medications before and after breakfast, but even those we try to look at and say, is there something else they can be on instead of getting something before breakfast or after breakfast? It provides more flexibility and more resident-centered medication given.
Yeah, and it's also sometimes called liberalized med pass.
Right.
That's another term that you may have heard. We're looking at it. We'd looked at it before, but we're looking at it again, and it's for the reasons that Kim speaks to. It does get to a more patient-centered med pass. Of course, this does not include antibiotics that are given on time and things like that, of course.
Right.
But the majority of the meds, it doesn't matter that much. And so yeah, it's a great concept, and you've had good luck. You've had good luck with it, Kim?
It's wonderful. It's much less stressful for the residents and the nurses. Because to give a medication at bedtime, well, I might go to bed at 11, but you go to bed at 7. And so the nurse can get in there and get the medication given before the resident gets in bed. And also just the timing of medicines, there's a lot less medicines between 3 and 6, which if you work 3 to 11, you come in, you get report, and everybody's getting changed and they're in activities and getting ready to go to dinner. It's such a hard med pass. And we have very few with our open med pass system. We have very few medications given during that time frame. It's much more manageable. So they give them as they come back from dinner, or who goes to bed first gets their meds first. It works really well.
Well, I don't know about everyone else, but Kim, you've inspired me on that one.
Yes.
You sit on that with a little more energy back in my shop.
Yeah,
it was really helpful for everyone.
We have started to look at it at Avalon. Should we start that? And thanks for bringing it up here. I have not gone there as well, and this is something for all of our members maybe to consider and discuss with their nursing staff. So I think what we as prescribers often don't consider when we, and I am just as guilty as everyone else, is like, how does this actually affect the patient's day or the nurse's day?
Right.
And
right.
to what detriment? So I think that open MedPass concept is something new that we have never really talked about at D2D. Right. And I'm so glad that you were bringing that up today. So that is something that maybe everybody can take home as a little homework and say, well, maybe I'll bring that up with my DON, or what else can I do to make the med pass easier? Because our nurses are often just med passes, and that is not a very satisfactory existence. Plus, it's not beneficial for the patients. I have one more question for you. How much time did it take you?
I do have one more slide.
Oh, I'm sorry. I thought we were.
That's okay.
We were done given this awesome slide here.
Yeah.
Oh yes, of course.
Hospice. Yeah, hospice. When someone goes on hospice, it's really a good idea to review their meds. It's a different avenue we're taking. So, what medications are causing them, discomfort or extra lab work or what have you, what can you get rid of? And as they progress in hospice, it's good to look at the meds because it changes. As the resident may decline, the need for some medication changes, to provide comfort for that resident. So, yes. And I will say, I did not think about it until we talked about the open med pass. When we transitioned to the open med pass, it's been a couple years, so that's why it didn't hit me, that we did deprescribe medication during that process also, as we were putting in the new times. It did cause us to think about the resident and the medications they were on and the residents' lifestyle in the facility. And we were able to, maybe decrease the amount of time or decrease the times of them being interrupted to get it, so they could get their medications at a time that was good for them. Yeah.
Who were your biggest losers, or what were your biggest losers? What medication was your biggest loser?
At first, it was the PPIs, because I went to I approached, sometimes, you go to the nurse practitioner because you think she's going to be on board maybe more than the physician. But at first I was shot down about the PPIs. But I changed I went to the doctor and got her to be on board with me. So that was initially the biggest loser. And the biggest loser, again, at first, was looking at the whole resident, a few a week it just didn't reap the rewards of looking at each class of medication.
All right. Well,
we have some questions.
Yeah, there are some questions. That's what I want to pivot to. So yeah, maybe Michael, would you
Sure.
like to talk
Yeah.
about aspirin and statins?
Yeah, and actually, one of the first things, it was kind of a cool dialogue and between Ivan Wang and Colleen Hicks. What about the potential benefit of anti-inflammatory properties of turmeric for arthritis and other conditions? And then Colleen Hicks said, what are the risks? Turmeric can cause nausea, diarrhea in higher doses, prevent absorption of iron, leading to anemia, blah, blah, you know, on and on and on. And I thought that that's an excellent conversation. I think the key word that I might want to focus on is potential benefit of turmeric, right? Not the evidence that says that it is really helpful, but the potential benefit. And I think that Colleen did a nice job talking about sort of the downsides of turmeric. Any comments on turmeric?
So I did not have anyone on turmeric, interestingly enough.
Okay. Okay.
So
Okay.
yeah, I didn't encounter that.
Colleen had a nice comment. If needed, antihyperstatins can be given at supper if you're concerned about side effects or early bedtime. That's a great comment. I thought I'd make sure I took note of that for everyone. And Kim, you spoke about aspirin. Colleen also mentioned that a hematologist CE session spoke to aspirin as long-acting on platelets, and she doesn't understand why it's ever given daily. So good comments, sort of reinforcing. A very near next talk for us will be from a cardiologist, where we will talk about the use of aspirin in the elderly, the use of statins in the elderly. Rodney Sharp asked for documentations about statins and folks over 85. If you could, wait till we get to that, and then we'll be able to give you a full response on that. Colleen spoke that, hey, Docosate is considered by the local geriatrician to be no better than water. There's a lot of evidence on that. There's and Allison gave a big thumbs up, true on Docosate. Liza Johnson, I feel like I need to look at every bunch of these, everyone's medication, so much polypharmacy out there. And I really appreciate that sentiment. And you know, maybe Kim's strategy of working with her team, looking at patients and classes of drugs might be a way to sort of wade through that, because it sure is a lot. Colleen had said, always make a recommendation on which meds should be discontinued. Don't just assess or ask. I think that's a really assertive way to get to deprescribing. Start on the assertive, make the recommendation. Here's what I think we should do and why, as opposed to let's do an assessment for whether we should, right? It's just a very forward use of language, which really can have an impact with caregivers. And Susan Snyder was, hooray for the open med pass. So there's some more kudos for the open med pass, the liberalized med pass, whatever we want to call it, but I think it's something that many of us will be looking at. Sabina, those are our questions for today.
Yeah,
Thoughts and comments.
And I think you mentioned that there are no recommendations on statins coming out, or I think they are already out. So I think that will be a great topic for next time to review. The other thing that I wanted to ask Kim, but our general audience, last month, we had an excellent, outstanding presentation on deprescribing seizure medications. And I was wondering whether anybody has taken that class of medication under the lens, so to speak, and has started deprescribing seizure medications. And what were your experiences? And this is anybody, and you can feel free to unmute yourself if you would like to, for brief comments. And Kim, you and I talked about that yesterday, actually.
Right.
Do you want to just comment on which seizure medication is on your hit list?
I'm gonna look at them all.
Yeah,
Yes, I
yeah.
haven't had a chance since yesterday afternoon, but I am gonna look at them all and see what we can do. Yeah.
Well, what you mentioned to me yesterday was that you had certainly have taken a closer look at Depakote.
Yes, for
And so
behaviors.
yeah, for behaviors. And
Yes.
tell us a little bit about that.
So we do have 3 residents on Depakote for behaviors, and we are going to look at them tomorrow with our psychiatrist to see if it's really beneficial or not. I'm not sure. I'm not sure it is.
It is certainly
So,
an off-label use.
use. Mhm.
And I think those of us who've had the pleasure to look at the new state operations manual interpretation,
Right.
we are all aware that any psychoactive medication now needs to undergo a GDR process and will be closely scrutinized. And I think that is with good reason, because many of these are given off-label and just because maybe you don't know what else to do, instead of looking more closely at behavior root cause analysis and so on. What we've talked about this in this forum extensively, but the Depakote is probably a medication that stands out as this category using a unapproved medication or unapproved for this indication medication has been very popular, and there just isn't the evidence behind it. So, okay, so I haven't heard anybody who went, I just had a gabapentin today, DC suddenly, and it should be tapered instead.
Yes.
Colleen, do you want to talk about that a little bit? I mean, usually I am always for tapering, actually, no matter, unless there's an emergency, but just because we deprescribe doesn't mean, okay, diaphoresis and confusion. So just because you deprescribe doesn't mean we need to be careless about it. In fact, we should always use extra caution in the deprescribing process because we are taking something that has potentially worked away, although we don't necessarily have evidence at that point. Okay, thank you for that comment, Colleen, that an abrupt deprescribing of gabapentin did have diaphoresis and confusion effects.
Yeah, and you are correct. Gabapentin should be tapered.
What would a tapering plan look like, Michael? Let's say they're on 300 TID, which is a fairly kind of classic dose. Would you just go down 100 every 3 days? That's kind of what my instinct would be, but what would you do?
And no more than 300 milligrams every 4 days is a recommendation that I'm seeing. Okay.
All right. So deprescribe, but do it cautiously and make sure that you exactly know what parameters for deprescribing are. The medication that stand out most here, of course, benzos and beta blockers. We all know about those that need to be deprescribed very carefully.
I also just read an article from, I forget where it came from, but about deprescribing antidepressants and how slowly they should be deprescribed. If someone's on Cymbalta 60, maybe they go down to 60 one day, 40 the next for a month or 2, and then, go to 40 every day, just very, very slowly with those medications.
Okay, next slide, please, Alicia. All right, as we are coming to a close in this office hours session, we want to tell you that next month we are going to talk about statins, aspirin, and antihypertensive. This is a big field, but it is these are medications that almost every one of our patients is on. And before we are winding up the D2D process in December. Want to really make sure we touch on this, and I'm personally really looking forward to this particular session, and that will be October 20th at 4:30 ET again. And so we're going to close today with a very special thank you to Kim. I think, Kim, you have just done a beautiful job for your facility. I personally wish I could clone you and get you into some of my facilities. And I mean, what a gift to your patient that they have such a involved and educated and kind and collaborative director of nursing. You have taught us all that you don't assume that every med has a benefit. You look at the risks, and that includes medications or supplements such as turmeric or whatever. All medications have risks, and if we don't need them, we don't need to take those risks. Let's look at open med passes as a little homework. Keep that discussion going, and we really want to thank you again for coming on today and share all the things that you did, and take that as an inspiration for all of us to work very closely with our DONs.
Thank you so much for having me. I appreciate it. It was a lot of fun.
All right. Thank you, everyone, and we'll see you next month. Bye-bye.
Bye-bye.